Where it go?
Okay, good morning, everyone, or afternoon for some of you on the East Coast and in Central Time. Welcome to our January 2026 kickoff home health Q&A. We appreciate you guys registering and getting on with us, and we hope that this is an interactive meeting, so please use the chat if any questions pop up, because we have a feeling there's going to be one really hot button issue, that there are going to be many questions, and we may or may not have the answers, but we're monitoring it closely and have been in touch with CMS over some things. So we'll share that with y'all as well. Our graphic today is about the Chinese zodiac. This year is the year of the horse. I personally am a fire horse, and I warned Cindy very early on that she needs to look out because it's my year. So with us today, we have Scott Curry, who is our manager of our contracts. He's our contract liaison and make sure that everything gets taken care of on our back end for IT. And Cindy Kraft, the other owner of K&K, who kind of goes without an introduction, but those of you that are here first, I wanted to make sure that you know who all's on here. I'm Sherry Teague, the other owner of K&K. So with that, Cindy, are you ready to get started?
I am ready, Sherry.
Okay, here we go. We got some great questions that were submitted by listeners and subscribers. So thank you guys very much for that, because it helps to improve what we can get out to folks every other month. So question number one, regarding the acceptance to service regulation, can you please specify what information needs to be included on an agency website in order to meet the requirement that is available to the public?
I wanted to make sure, Sherry, in preparation for this, that I went back and looked at the acceptance of service regulation to see exactly what it said, and then thought you and I could talk a little bit about what that might look like. Because I think with many regulations, it gives us a, kind of a framework, and it doesn't really necessarily give examples. So I want to make sure we take some time to do that today. So I'm going to read what the regulation says, and then we can talk about that. So make available to the public accurate information regarding the services offered by the home health agency and any limitations related to types of specialty services, service duration, or service frequency. So when we look at it that way, we ended up in this situation out of concern by referral sources, basically, that they were struggling to find home health agencies capable of accepting their patients based on the services they needed or any delays related to those services. And so I believe CMS saw this as a solution. I'm not necessarily sure it's the best one, and I'm sure there's lots of frustration of trying to be compliant with this thing. But the reality is, they're trying to get us to be proactive about what we have and what we don't have. And I'd like to start us back and forth, Sherry, with a personal example, because I had a family member very recently referred to home health, and they were referred for nursing for all three therapies. And the nurse came out, did the admission, everything signed, sealed, and delivered. This is what you're going to get. And then it wasn't until an evaluation from OT a couple days later that I was informed that they didn't have a speech therapist that covers this area. They got somebody, they're going through orientation. It was going to be at least a couple of weeks. Now, in my family member situation, it was like, well, great. I would have liked to have known that, but I also know that this is not a major swallowing issue that I'm, really, really worried if it waits a couple of weeks. But it made me think about, in looking at this question today, I should have been told that ahead of time. My family member should have known going into it that these are the services at the physician's request and the facility she was coming from, and you don't have it for X number of weeks. So I think that's why we end up here of a rule that basically says you have to disclose this publicly because people want to make informed decisions. So as a former agency owner, Sherry, what do you think about what it's asking for? I mean, it's not just because you can go to Care Compare right now and it'll say you have, nursing, PT, OT, speech, but it doesn't talk about any staffing concerns or delays. It just kind of lists them.
I think that we ought to have a form that we update and be part of the admission packet or part of the introduction packet, especially when we see discipline that we may not have the availability for a period of time. We actually had a client recently that told us that they're in an area where they have someone who cherry picks the referrals, and they get more referrals than they can handle. And so they let their referral sources know up front what kind of a delay they're experiencing. I think adding that to that call and having a form that you put into the welcome packet is something that says we may have these disciplines listed on Care Compare. However, availability is based on where our patients show up, some sort of disclaimer, and then update that as needed. Especially, I think the point of this is to update what's showing on Care Compare, right? And have that. Not, that's your largest advertisement of what Medicare sees that you're offering. So that's what you need to be held to. And I think it's super important that we follow that guidance to what the meaning of it is, because sometimes the letter on this one can be confusing.
Well, I think part of that has also been that we're still kind of in limbo around what the directions are, the interpretive guidelines to the surveyors about this.
Yes.
So people have gone through survey and said they didn't even ask about it, and others have varying experiences. So that kind of adds to it. But I think that there's the what needs to be on the website, which is a public facing, this is the services we have, these are the services we don't have. But it also goes further in talking about any limitations related to any specialties, frequency, or access. So I think about things in my former life as a rehab director. We would be in situations where we could never provide more than 2 times a week speech therapy because we only had one and she would only work on Tuesdays and Thursdays. Now, in light of this, that would be a disclosable thing because you may have a patient who needs a higher intensity than that. And as a referral source, if I know ahead of time you can only do twice a week, then I may have to look at another potential source. I think some of the sore spot and why I chose speech as the example is what we'll hear is, but everybody's in the same boat. Nobody else around here has an aide either. Nobody else around here has the social worker. It isn't about you can't go anywhere else anyway. It is about responsibly reporting any issues limiting their access.
Right.
But I think the part that goes further, and we have talked about this on previous Q&As, but I just want to briefly touch on it here, is the specialty service. I think, our minds gravitate toward maybe I don't have a wound specialist, or, I do basic wound care, but if maybe we don't do wound vacs. I mean, those are all things that based on our organizational decision making, our staffing situation, it may be that we have nursing, but there's certain things within that, IVs as an example, we don't manage those. That needs to be disclosed. But I think the one that keeps getting overlooked is maintenance therapy.
Yes.
Because I keep getting told we don't do that here. Okay, but that is part of what needs to be disclosed. That is a specialty service within therapies, and you have the right, just like with wound care, to say we don't provide it, but that has to be disclosed. Because if a patient does need maintenance therapy and you do not provide it, then they need to be given options, either to start with another agency or potentially be transferred to another one. If we've done a restorative focus of care, reached a point where maintenance is appropriate, we don't do that, then what are their options? So I think it's a little deeper than just kind of putting on my website, I have these services. It does say that it needs to be reviewed at least annually, but does reference when circumstances change. So if I got a new hire, if I had something change in that, and so keeping it as current as we can. And I just want to wind that up, Sherry, with I understand it feels like yet another burden, yet another face to face, because some people weren't getting the right information. Now we have to jump through hoops. But I think we just need to look at it from the perspective of the patient, the person who has these needs. That to, again, back to my example, you accepted my family member, you admitted this, and then you gave me oh yeah, but by the way, you can't have it for several weeks. I probably should have known that before so that we could make an informed decision. Now, Sherry, I saw the question that popped up, and I'm going to go ahead and take it. Yes, absolutely. Medicare covers maintenance therapy. That has been part of the Medicare Part A home health benefit for more than 2 decades. It got a lot of attention in 2011 off of the Jimmo versus Sebelius lawsuit. And all that was Medicare being forced to admit you cannot deny services strictly on whether or not the patient improves. So K&K has been active in advocacy for maintenance therapy for this, I swear, Sherry, since the day we started K&K. And we
Mhm.
have many resources available, educational and informational about that. So if you're not sure what that is or how that would look, or if you're an agency who says, I don't need to know about that because my therapists don't do it, they are. They may not be comfortable enough to document it correctly or speak to it outright, but I have never interacted with a home health agency that when you dig into the documentation and the decision making is not actually performing maintenance. They are. The issue is, are you documenting appropriately, writing orders appropriately, and billing it correctly? Because there is a specific claims code. So that could be a whole standalone Q&A at some point, but yes, it is part of it. And if you're not sure or not comfortable, please feel free to reach out and we're happy to help.
And visit kandkhelp.com. We have
Yep.
products that can help you get to that point and recognizing what patients you're currently serving in a maintenance capacity that you may not be aware of. But I think it's really important to reiterate something Cindy said. This is about this notification of what you do and don't do is about getting your patients the best care and getting them what they need. So we need to be very diligent about that. There's a lot of information coming out of CMS where they're trying to make sure that we're doing that. And this regulation of having to notify what you can and cannot do is part of that. So I think all efforts are going to be appreciated. And if it comes down that you were doing it wrong, you can action plan yourself and improve it. Medicare nowhere does Medicare say you have to be perfect and know every regulation. You just need to be aware of why these things are happening. And why these things are happening is because some folks will get a referral for a service that they don't currently have, and then they'll go about trying to change the referral. They'll go about having their OT, or excuse me, it's more important that I say it the right way. They'll have their PT go out and say, well, OT is not really necessary. And I'm going to tell you that you need to refrain from that. That is a common practice that where nursing will go out and say that they don't really need therapy. Therapy will go out and say they don't really need nursing. You need to provide what is ordered by the physician and use your physician as a gateway to make sure that your orders reflect the care that you're providing, because it is not within the skill sets to identify those patients not needing a service. It is within your skill set to identify when they do, but not to exclude them from receiving that service. Cindy, do you have any comments on that?
Well, my kind of wrap up thought on that, Sherry, is we've seen the trend in having one service assess the need for the other.
Mhm.
That magically doesn't occur when staffing situation changes.
Yep.
So I look at it and say, if that is acceptable, that you're going to have PT screen everybody who needs OT, then that should be what you do all the time. But that's
Yep.
typically not what it is. It's our backs to the wall. We're going to do this for a little while. And then wait a minute, we found another OT. Now stop that. We want all the OT referrals again. I think we just need to be careful of what we say is the correct way to do it when that can pivot in a heartbeat when the staffing situation changes.
Thank you so much. Okay, question number 2. Are we ready? By the way, just want to mention that you will get the recording of this after we're finished. Please feel free to share it far and wide. We want to get this information out to as many folks as possible. And we will be providing email addresses where if a question comes up that we don't have the answer to directly, we can communicate via email to get that answered for you. Okay, question number 2. We have several clients demanding the 8 hours of aid services per day for 28 hours per week, since they see that when they look at the benefit manual. What are good ways to explain that what the aid benefit is and what it means to be medically necessary? I'm not sure of any agency that can staff aid care like that, especially when there is an able caregiver available.
Oh, boy.
No boy.
That is a loaded question on multiple levels, and I really wish I had a simple solution, because from the beneficiary's perspective and beneficiary advocacy groups, that is what's in. More aid is definitely in the regulation. And I think we've ended up kind of, you could call it self-fulfilling prophecy. If you want to be more grumpy, it could be cycling the drain, in that payment methodology has not necessarily aligned with providing that high of aid. So you have what it says they could qualify for, and then you have the reality of what it costs to provide that. Now, some folks are quick to say, see, that's the problem. Medicare is not paying us enough to provide this level of aid. But we ended up here by not providing that amount of aid. So it's kind of like, here's the payment rate, but wait a minute, you don't really provide that amount of aid. You historically provided this amount of therapy, and now all our data says you're providing significantly less therapy. And I'm not paying you per visit for any of this. I'm giving you episodic rate. So if you don't provide this, I'm not going to give you the money. And then we say, but I'm not providing it because I don't have the money. So that's how we end up here, which is we make decisions and look at the reimbursement and what can we reasonably do. And then if we're undercutting something, then CMS sees it as, well, why would I give you that kind of money? Because you don't have any patients that have aid that high. If anything else, I remember, Sherry, starting in this space over 30 years ago, and aid services were like everybody. I mean, they literally hung up a sign in the summer, it's getting hot, increase use of the aid. Now,
Yep.
yes, that was so long ago, it was pay per visit. I mean, way before we got put on budgets. And aid was like all the time, everywhere, just like BID nursing visits. And payment changed, behavior changed, and now it's kind of hard to go back to CMS and say, well, it's kind of your fault because what you pay me. And they say, well, it's your data doesn't say you do this. So I recommend, as far as managing this, Medicare advocacy. I always get their name wrong, Sherry. Judith Stein.
Medicare advocacy counts. I will look it up. Go ahead.
Thank you. Judith Stein is the lead attorney. She was one of the lead attorney in the Jimmo versus Sebelius case. But a group she participates with has quite a few resources around what the benefit really is. Now, when you look there, it'll talk about maintenance therapy. It'll talk about the Jimmo decision. There's a lot of advocacy they do about this aid issue. It's very clear, though, in that beneficiaries should be receiving aid when that is what they're entitled to. And yes, the benefit does say a significant amount more than I typically ever see when we audit records and work with agencies. So you may say, well, you didn't answer the question. It's tough because they're right, but we also have to be careful about, just because it lists that amount in there doesn't mean you just get it because you have a skilled service in there. I think that's kind of what we have to look at when we talk about what patients need versus what patients want. And sometimes the informed family member looks at that regulation, or the patient does, and thinks that I get this because they may not need that amount. It may not be appropriate. Even if Medicare opened the checkbook for you, you may say, this person does not need that this situation doesn't warrant that. And so I think it's important to clarify for those individuals what realistically we think that they would benefit from. And if there is, more concern about these kinds of things, it's possible, I've done it, to direct the beneficiary to that Medicare advocacy group to work through that side in terms of CMS's accountability of, you have this in the benefit, you do need to be paying appropriately. Does that make any sense, Sherry? Because it's a tough spot. That is what it says, but the payment issue is.
I'm going to jump in there real quick, Cindy. As a former agency owner, it is expensive to provide aid services, but it's also expensive not to. Aids are a crucial part of the care that you provide a patient, but these are medically necessary aids. So if you explain to the beneficiary that what exactly that Medicare medical aid is going to provide to them and how limited it will be compared to a personal aid, I think sometimes patients will choose to go with a personal aid versus a medical aid. If you say to them they are there to clean the wound or to make sure the hygiene is good, they are there to clear a path from the front door to where the patient has to go to their bedroom. This is all that they will do. They will not cook a meal. They will not do this. They will not do all these other things. I think if you completely can explain that a lot of your patients, particularly those that have a little bit more resources, will choose other options. And I'm going to throw a little caveat into this. Anybody that needs an aid needs a social worker. And I say that because there are many programs that are available through Medicaid. And I know that we've heard a lot about the legislation that has limited Medicaid, but there still are a ton of programs and waivers that can get significant aid services to your patients. And a social worker should have access to some of those ways of applying. And sometimes that you may have to provide an aid for a short period of time until you get a benefit started for your patient. And that includes your patients that have funds. There are ways that they can secure some funding through some Medicaid waivers because the government is incentivized to keep these folks at home. So they've set up some programs that can be accessed. But again, we used to, as a rule, if an aid was required or if the aid was requested, that meant that equaled an OT assessment, period, right out the bat. What exactly is it that aid is going to provide that's medically necessary from the nurse's point of view and from the OT's point of view? And then that limited benefit is what you offer them, because that's really all we're getting paid for. And Cindy, we've seen this. We've seen agencies. We know of agencies, and those of you that are on this will know of agencies that will not tell the patient that they're not receiving, that they won't receive an aid. That's one of those reportable things, guys. You need to let folks know, and it needs to be in your publicly facing information that you do not have aid availability in a certain area. Those kinds of things need to be known so the patient can make their best choice.
The other piece of that, Sherry,
by the way, it's Center for Medicare Advocacy. The website is medicareadvocacy.org.
Thank you, Sherry. I want to just add a little bit to that discussion. You brought up a great point of the social worker role. I also think that there are times where social work is an integral part of finding other community resources, volunteer groups, different options that may be at low or no cost that individuals could get that kind of help from, that the nurse, the therapist may not be as intimately aware of. Yes, K&K is known of being a big advocate for OT, but I say we're equally as big an advocate for the social worker.
Mm-hmm.
When I audit records and find out that, you can clearly see that it's like we provided the services, we provided an aid, and then in week 7, people are panicking what's going to happen, and because they live alone, and now what? And now the social workers ordered right before recert. It makes me wonder, could we have gotten that in sooner and had a better exit strategy or alternatives to be able to present to the person before we're near the end of a cert period?
And aides will round out your benefits so much. There's so many things that they can do, especially to assist with the clinicians in making this patient get towards their outcomes. It is an outcome booster to have aid services, good aid services included in your agency offerings for sure. But we need to get out of this mindset of rationing care. And it's happened since PDGM. And with the influx of private equity, you guys that follow our newsletter have seen us rant about this. We have to protect this benefit, and we have to provide the care that folks need. And I can't say that enough. We have to protect this benefit and provide what they need. And if you're a clinician on this call and you're being asked to change your orders, and we'll get to that in a minute, but you need to stand up for your license and you need to stand up for your professional opinion. And so I think it's super important that we support that, and Cindy and I both do. And we try to reshape how the trends that are going, where we're doing one time a week for everybody, no matter what's going on with them. So Cindy, are we ready to move on, or do you have further thoughts?
No, I'm ready.
Okay. Number 3, which parts of the 2026 VBP updates, value-based purchasing updates, took effect on January 1, and which parts will take effect on April 2026?
Well, I think there's a little bit of a mix-up in the question. I think, and I attribute it to us getting our final rule so late, that it came way closer to holidays than it normally even does, and kind of may have gotten a little confusing. When they make changes to VBP, it is for the calendar year. I did some quick digging, and if I find something else, I'll be happy to circle back to this group and clarify, but I can't find anything that says something's tied to April. What's tied to April is E2. April 1, it's not an April Fool's joke. I think it's funny they picked that, but that's when we get OASIS E2. That has nothing to do directly with the changes to VBP. The biggest change for VBP in 2026 was the addition of 2 metrics from the OASIS related to self-care. And as a member of the technical expert panel for VBP, please don't hunt me down for saying that. There has been vigorous discussion over the last year that, yes, it was good to move away from the improvement model of before to go to the discharge function score, to really make it GG and make it, focusing on different things. But it became very apparent that the list of what they selected, because it had to be items that are consistent across home care, skilled nursing facility, inpatient rehab, and long-term acute care hospitals, the ones that ended up in that score don't really fit well for home health. If you look at home health in isolation, because the ability to roll, to eat, to sit up, these are pretty low level activities that most of our patients kind of got to do before they even get to come home. So they feel like these are going to kind of be topped out already. And how can you be measuring quality in home care and basically remove the heavy hitting self-care ones? The problem is, because the self-care, the best bathing and dressing and all that good stuff that are in GGs now, but they're not in all post-acute settings. In particular, they're missing from the instrument used in long-term acute care hospitals. So for the short term, their hands are tied. They can't pull GG items that are not in all four settings. So they are going back to the 1800 measure for those. So is this a big upheaval? No, because we've been focusing on those 1800s for literally more than 20 years. And their impact on payment and outcomes and all the rest of it. So it isn't that something changed radically from my perspective that we have to do differently. They're just putting those in as a placeholder with the intent of ultimately making them all GGs in value-based purchasing and being able to incorporate some of those higher level tasks. Because without it, it looks like, I mean, we know in home health that if this patient can't dress themselves, bathe themselves, do those kinds of things, they can be medically stable, but can't safely stay home. So that's where we stand in terms of there. If you look at what items are listed, it still lists for 2020 calendar year 2026. The discharge function score is one thing. The 1800 ones that are involved are separate from that.
And a question came in, Cindy. I read that they added 1810, 1820, 1830 to TPS for BBP, correct? I'm not familiar with TPS.
They're individually added. We're not going back to a total performance score model of when it was the 1800s prior to going to the discharge function score. So is this ideal? No. And the technical expert panel would agree with you that it really should be self-care, the dressing and bathing rolled into the discharge function score, but they can't. So they are sitting as independent items, those 1800s, separate from the discharge function score.
And Cindy, I wanted to remind everyone that this is all by legislation. This was the Impact Act, I think, of 2005.
Oh gosh, yes.
Yeah,
It's been
so
around forever.
this is all, in order for any of this to be changed significantly, it would have to go through legislation at the federal level.
Yes.
So this is a law that was enacted that has just been glacial, sloth-like in being implemented. And it's the point of it is to get a continuous measurement tool across all the post-acute settings. So it's not
Sherry, some might still have PTSD at the mention of the CARE tool.
Yes.
I mean, when that started, we were being led down a path that all these 4 post-acute settings were going to have the exact same assessment tool. Well, that blew up because there are 4 different settings and 4 different patient populations. So to be compliant, they put the GGs in all 4 settings. They just didn't put the full set. And I understand why they left some of them out in long-term acute care, but now the downstream consequences are they're limited, that they can't pull them into one setting and not another. And I think, Sherry, part of what messed that up is that home care, you say it moved glacial, we were the caboose on the train.
Yes.
So now home health is getting into this going, hey, stop the presses. What do you mean you don't have dressing and bathing included in this? And they're kind of like, well, yeah, we're on the umpteenth iteration already for skilled nursing facilities. You guys are late to the party. Well, not by choice. So I think this is still a work in progress. The bottom line to me, though, is I understand the focus on VBP. I understand the concern about financial implications and all that other. But this goes from the OASIS measurement side, and OASIS sycophant that I am, this really speaks to every item, every time point, every time needs to be answered correctly. And we need to be working toward a positive patient outcome, whether that is improving them, whether that is stabilizing them, or trying to manage a decline. When it's which ones are we going to focus on now and how does the math work? That does not resonate with the people that are actually out there treating the patient. And I don't think that's going to get them motivated other than frustrated, as opposed to saying, let's just stop filling out OASIS items and hope they get past the reviewer and say, okay, this is the answer that was picked for our collaborative patient. What are we actually going to do to move this patient from a 3 to a 2?
And we have
Right.
to get to the point where we are providing the care that they need and we can document it appropriately,
Mhm.
because sometimes, believe it or not, the OASIS is too big of a measuring stick, meaning there's too much distance between a 3 in ambulation to a 2 in ambulation, but there can be significant improvement between those. So we have to be good documenters to explain what the gait pattern looks like. What kinds of things are you improving? Are you working on a drop foot to keep them from falling? That may not change them in your outcomes from a 3 to a 2 on ambulation, but man, it can impact a patient and their function and their safety. So
But
I think
I would argue, Sherry, it could, because if you look at your example, response 3 says they need to be at least supervised whenever they're walking. And response 2 is they need to be supervised intermittently.
right.
So they may still need someone on stairs. They might still need someone on uneven surfaces. But if I can get you from continuous to safe within your home, you move from a 3 to a 2.
Right.
Now you go outside and you need somebody there because I don't like you on the grass. Well, that's better than when I thought someone should be here the entire time. But I don't want to go poke the OASIS bear because that could consume the rest of this thing. And I know we have a very interesting question for.
Okay, well, I just want to add to that there was an additional right. So the understanding is that the OASIS portion of total performance score, thank you for clarifying that for me, is now improvement in M1400, M2020, M1810, and M1820, M1830, as well as meeting or not meeting expected discharge function scores.
Correct. The addition of the 1800s is not rolled into the discharge function score. It
Okay,
can't be because those are GGs.
got it. Okay, so we put up another slide. We're doing a survey, and we do this every year, and we want to have some feedback. Sometimes we get in our own closed loop, and we want to know what's going on out there and why. It's a very short survey. It's literally 10 questions, with the 10th one being your email. Include your email address and you will receive, we're paying you for this survey. We're paying you for about 5 minutes of your time. You will receive a 20% off coupon that can be used anytime this year on a single item or multiple items in the same order. And you're also receiving, for the person who asked about maintenance earlier, you're also receiving the very first session of our maintenance series on fundamental regulations for maintenance therapy. It's a 15 or 20-minute long session, and you get the handouts as well. So please use the QR code or use the link and fill out that survey for us. We're going to be running this survey till the end of November, or end of November. Goodness, no, end of February.
Word.
Yeah,
Okay.
end of February, so we can get as many responses as possible, because we're trying to see why things are happening in the industry and how we can help. Okay, any other statements about that last one, Cindy? Because here
Nope.
comes the multi-parter.
Yep.
Okay. Many of you know, and maybe you don't know, that there are social media pages that have formed of different clinicians in home health, different situations in home health. There's a coding page, there's an OASIS page, there is a PT, OT, and speech page. And if you are not currently following that, you should, because there's interesting things that get posted on that coming from the clinician's experience in home health. And I think it could inform you on how you can react and work with your clinicians in situations. So the fourth question is this one. And it came straight from the page. And those of you that are members of that page and you're mad at me for telling your bosses that page exists, I apologize. But most of the posts that go on there are anonymous anyway. So just FYI, this was an anonymous post, and we felt like that it was important to bring to the group. I am a PT and curious how everyone documents level function during the first visit, the level of function during the first visit. I am being told to rate lower, so there's room for improvement. As an example, during an evaluation yesterday, we did endurance training in which my patient and I walked 200 feet inside her home. When I submitted my work, My supervisor said to put 50 feet so that we can build up to 200 feet, even though 200 feet is what happened. Then he added that I shouldn't document above 100 feet. If I need to extend services, then there is still room for improvement. If I document that we start at 200 feet, then insurance will consider this as beyond our household difference or distance and not cover the services.
So Sherry, when you sent the questions to me and I read this one, it kind of gave me heartburn.
Yes.
Because this is why we ended up taking the question and breaking it into two, because there's a multitude of issues in here.
Yeah.
First and foremost, my thought for this individual is, okay, so you have a supervisor telling you that although they can walk 200 feet, put 50. Would the same supervisor tell a nurse, well, wait a minute, the blood sugar was too good. Put it at a higher number so we can show that we're impacting it over time. Or, put their blood pressure a little higher than what you actually read, because then we can show how it gets better while they're our patient. Now, anybody who's listening to this, particularly who is a nurse, is horrified at that. No one would tell a nurse, make the blood pressure number higher, make the blood sugar number higher, because then it makes us look. No, they wouldn't, which is why I would say absolutely not. I am not going to make the distance shorter so that I can show improvement. If this individual can do 200 feet during my evaluation visit, they can. As a matter of fact, why are we talking about a number when we know that the GG item talks about a minimum of 150 feet and the M1860 doesn't have distance connected to anything? So the issue then becomes, first and foremost, if they went 200 feet, it's 200 feet. The devil's in the details. Okay, if I put 200 feet independently, then somebody is going to wonder, okay, this person seems pretty decent. Why can't they go to outpatient? Well, it could be that today was a good day, or there's dyspnea, there's pain, there's other. But again, if I put independent, that's a powerful word when a clinician uses it. If I put the patient as independent with their pill planner, independent with this, I've blessed their performance. And so there's really no take backsies of I said it's independent and I should work on it. So we have to be very careful. I would expect that 200 feet contains details you referenced earlier, Sherry. Is there a foot drop? Is there a foot drag? Is there a cadence issue? All those things, PTs out there and PTAs, you remember, we were never taught distance, device, and level of assistance was it. The reason it takes a therapist is what's wrong with the gait specifically, and what are complicating factors that show it isn't just get the daughter to walk them further. It needs to be a therapist for these reasons. The second part of this, though, is the distance issue and fear of how far is too far. I like to redirect people to when you look at the research around ambulatory distances, and not a home health study, not an outpatient study, just looking at the geriatric population, what is the minimum safe gait distance someone needs to be out in the community? And that is over 1,000 feet. Let that sit for a minute. So what if I'm in QA in a home health agency and I go pull this up and I got this patient documented to go in 750 feet and the therapist wants to continue? The problem isn't the number. The problem is, have we given appropriate context? And I love how all of these example numbers, Sherry, and our own documentation, it always ends in 0 or 5, which means let's just own it. We didn't actually measure it. That's a big old guesstimate, because there's no way in reality the distance between where I am right now, my bathroom, my kitchen, and my driveway ends in 0 or 5 all the time. So what happened is therapy documentation started to collectively slip to just making a number, and a goal's a bigger number, without the why, without the, are they in assisted living and they live 400 miles from the food? Are they in a mobile home? Do they have stairs? That kind of all fell off. And so when it just looked like, as Sherry's heard me say so many times, long walks to nowhere, yes, payers started going, that's a little too far. That's a little too far. That's too far. And as opposed to saying, wait a minute, I know why I went that far, and I know why my goal is that far, we reverted to, well, then never say a number bigger than X. Don't say this number. You're good up to 200, but at 201, that's it. We're done. They're not homebound. we have to be able to look at this and say, what is the patient specific situation? And one of my favorite is when we try to blend it into, it's to get to the mailbox. Well, I can tell you right now, in my house, to get to the mailbox is 800 feet. Yes, I've measured it, 800 feet to get to my mailbox. So where am I going with my 200? I can't get to where I need to get to. So it's really about that context. But I think, Sherry, all of those layers end up in a quick fix of just make the number lower. First and foremost, no, I'm not going to lie on my assessment. I do need to make sure I'm describing the issues related to the gate, regardless of distance. And then as far as how far I can go, I need to explicitly lay out what this patient needs to do. What if the patient's only transportation option is public transportation and they have to be able to get to the bus stop? How far is that? I mean, those are the things we've kind of let ourselves believe that it's about the number. And if all we talk about is distance, device, and level of assistance, and here's the bigger number at the end without the rest of it, I can see why payer sources just decide, well, this is easy. You go further than X, I'm not paying you.
Oh, 100%. And I think that there is a significant compliance issue in that question that was posed on the
Yes.
page. And I would honestly, if it was a friend of mine, I would, and Cindy, I'm going to speak freely. I would tell them to run, not walk from that agency to another agency. And I say that because you cannot put your license at risk. And that is a perfect example of somebody asking you to do that. And whether you misinterpret it or not, it's your license. So your gut is what matters when you come upon these situations. And I think asking for the regulation is a good idea of where they've seen that. And inevitably they're going to hear this, right, Cindy? Well, we've been denied based on putting too long of a distance. And I'm going to tell you, CMS is not allowed to deny on a single issue, on a single statement in a note.
It even references ambulating a certain number of feet as an example of what they can't use as a single denial reason.
Yep. So there is more problems with that chart if it got denied than just the distance that they were walking. And so using those functional statements like patient must go see physician on 3 days a week or twice every month because of this condition, the distance from their car into and out of the doctor's office, those kinds of functional statements could not be more important in those situations. So, accessing their care and accessing the things that they need are what we should be working towards, not a distance. But clarifying it with a distance is okay, but saying why that is important is absolutely necessary. So are you ready for the second part? And I'm going to switch screens because we do have a compliance page on our website that I wanted to send everybody to, and you can reach us through this. Just take your phone, the photo function on your phone, and look at our T-Rex QR code here, and it will take you straight to the page. It'll bring up the link and it'll take you straight to the page. But take a moment and peruse what we offer. And Cindy and I are very clear. We do not do everything when it comes to compliance. The things that we do extremely well. However, we've made a very important decision to get relationships in this industry and to sift through who we think are the hucksters and who we think do a great job. And so we do have partners that work in other aspects of compliance that we can help you with. So anytime we put a link in our newsletter that says click here for more information, that is not agreeing to buy anything or agreeing to be sold anything. Sometimes it's just offering to be a resource to get you to the correct provider of that can help keep your agency compliant. And somebody put a statement about this thing that some people, the waters get muddied between commercial insurance and Medicare. 100%. Traditional Medicare, if I hear one more time, Cindy, that they are waiting on an authorization on a traditional Medicare patient, I don't know what's going to happen, but it's not going to be pretty.
But I do understand that there are some private insurers that try to cap distances. I've seen agencies get hit with you can't walk more than 25 feet because then you could go to outpatient. I think that needs to be fought with documentation, with literature, with whatever it takes, because if we just go, well, the solution is don't ever walk more than X, they win, and that distance is just going to get shorter arbitrarily because we know that their primary goal is to not pay for anything. So it can get us some bumps and bruises in the meantime, but a solution of fudge the number or don't go further than X just becomes what we're stuck with, and it tends to shrink over time. But Sherry, I want to make sure I can get to my 2 OASIS updates. So let's hit the second part of this question. At least I'm sitting down.
Okay. This is the second part of that question. When I visit a patient for a reassessment after the PTA has been working with them, I think that the patient needs more therapy, but the PTA has been documenting that the patient is modified independent for bed mobility transfers and ambulation up to 400 feet. There is still hip pain and the patient wants to continue. How do you extend therapy if the PTA is documenting this way? Should I tell this PTA to document everything as supervision assistance instead?
Okay, so just for everyone's edification, the same person who was grousing about being told to turn 200 to 50 is now asking, should they tell the PTA to document something different? It's just like, okay, seriously, let's just think about it. The bottom line for that whole second part of that question for me, and I sincerely and respectfully hope I live long enough that we just stop using modified independent in the home health space. I'm just, Sherry, it's been a long week. I'm a little punchy. I don't care that it's in your EMR. EMRs added them at the request of agencies who said they wanted it. And it is not an acceptable term outside of the FIM tool, which is used in inpatient rehab. As a matter of fact, to utilize the FIM tool, you're supposed to go to special training first before you use that. And in the context of the FIM tool, it has a specific definition, which is they are able to complete it independently, but it took extra time or it took a piece of equipment. Well, I always want to say, if you're going to say independent but time or independent but equipment, why don't you just say independent and how long it took, or independent and what piece of equipment it was? Why are you using a term that means two things outside of the fact you're not using the FIM, you don't have the scoring guide, nothing? What happened is many therapists were exposed to this term and just carried it with them. What happens is it's read as independent, modified, whatever, who cares? Don't know what that means outside of the FIM. The patient is independent. So the way that question's worded, you have a PTA saying that they are independent with those activities, inclusive of walking up to 400 feet. You're done. I mean, unless, again, if you have a contextual reason to go, you know, at 400, they're good, but they really need to do 600, and at 500, bad things happen, so I still need to work on it. That's one thing. But the way to solve that problem is prohibit modified independent. Yeah, I get fired up about many things. This is one where no one is going to convince me otherwise. And if you have therapists that still want to say, I know what that term means, it's okay, I can use it, I say, okay, fine. So if we're going to be able to take terminology out of one tool and just start using it in our documentation, then I think what we need to do is embrace Gigi's concept of touching assistance. And we're just going to start as therapists utilizing touching assistance as an acceptable term. I mean, it's in the OASIS. So why can't I just take it out of there and put it in my eval that this person bathes with touching assistance? Nobody'd be okay with that. That term belongs in OASIS. It has a definition in OASIS, and we know how we use it in OASIS. But it stays there. I'm not going to take it out of there and put it over here and try to say everybody would know what that means. I mean, bathing with touching assistance sounds like the beginning of a special victim unit episode. So that term just causes so much problem, Sherry, and you can't walk it back because you're the one who said they're independent at these things. Modification doesn't matter outside the context of FIM.
Cindy, literally a reviewer at the Palmetto level, at your fiscal intermediary level, the only word they see of that two-word statement is independent. That's all they can see.
Correct. And if you think about how it's defined in the FIM, you're independent, but it takes extra time. Oh, well, then it takes you a little bit longer. You're independent. You're independent with a piece of equipment. Well, the argument I hear there is, well, yeah, they're independent with a walker, but we're trying to get to a cane. Then say that. Don't say modified independent. And then, oh, yeah, I'm kind of moving between pieces of equipment that I haven't identified. I mean, that term just causes so much problem that I would love to see it. And anytime we've had an opportunity to collaborate with an EMR, one of the first things I do is tell them to get that out. And one of the first things I hear is, but the therapists want to keep it in. It's too risky. If you want to do that, do the whole FIM tool, get certified, try to do that. But that term, I've seen more denials that tie to that. And there's really no way to explain it away. Sorry about that, Sherry. It
That's
seems to me
okay.
to be a quick fix to just say, just don't do it. Describe the situation, how much help. So maybe they are supervision, but modified independent doesn't mean supervision. So the solution of tell the PTA just to call it supervision is not a solution.
Yep, and I apologize. This is home health, right? I've got some things barking in the background, some little four-legged creatures. But Cindy, you had an update that's so important. You have two updates on the Oasis that you want to share. And those of you that are members of the Club Oasis, we are going into our second year starting March 1st. So if you need any information on Club Oasis and what all that entails, please reach out to us at our contact, knkhealth.com contact. But here's information on how to reach us after this. If you have a question that may arise, and our next session is going to be March 19th from 1 to 2 p.m. And go ahead and register and get your questions in. And if we did not get to your question on this session, please reach out to us by email. We would love to hear from you. But also, on last note, and then I'll let Cindy go, is Cindy and I both have new email addresses. We're trying to update that, and it's like watching someone who's in their 80s try and hook up an Xbox. This process has been long for us, and Scott's laughing in the background because he's the one that's had to walk us through it. So thank you so much, Scott, for that and your patience. And Cindy, go ahead.
Okay, so two things. One, when we found out that E2 was going to start on April 1st, I think there was a bit of a sigh of relief. First of all, doesn't have a whole lot of substantive changes. They're pulling the COVID questions that were supposed to go in and got diverted, and a couple of tweaks. And it was like, great, I finally don't have to deal with this as an agency during the holiday season. I can just kick that can down to April 1st. Yeah, there's been a couple issues. The one I want to talk about today is that based on Q&As, there's been a change to the definition of a fall. And they changed the definition officially January 1, but it doesn't change the guidance manual for E1. It is in the guidance manual that clearly says effective April 1st for E2. So between January 1 and April 1, we're in this weird limbo where officially the definition of a fall changed, but it's a Q&A issue that they decided to make the new standard April 1, but our guidance manuals are out of sync. What did they change? First of all, I don't think it's a big deal change, but it is a change. And this change affects how a fall is defined in item 1033 in terms of risk for hospitalization and the J question as to whether or not this patient fell. Now, for some of you who are holding your breath and say, did they get rid of the interrupted fall insanity? Nope, that stayed. Okay, this idea that they could have fallen, but somebody intercepted and it's still a fall. No, they left that. The one thing they changed was previously, the guidance clearly stated that if the patient essentially hit the floor by an external force, so if somebody pushed them or a door swung and hit them, it was not considered a fall. That is the truth, according to them, all the way till December 31st of last year. On January 1, if you get hit and knocked over, it's a fall. And that is confirmed in the guidance around those two questions in the E2 manual. So this to me might feel like, well, that's not really that big of a deal. I bet my clinicians probably didn't know that anyway. Or somebody's going, I didn't know that. I figured if you got whacked and knocked over, it was a fall. Well, technically, the definition prior to January 1 said no. And from January going forward, it's a yes. So something you will need to revisit with your staff sooner than April 1 because it's in force now. That has led to some Q&As, and we saw that the November Q&As the October ones were very late. And then they announced this week that there are no January Q&As because the information didn't need to be dispersed. I'm like, wait a minute. So you didn't say there were no questions. You just don't think everyone needs to see whatever you answered, which that's a conversation for Club Oasis because I have some thoughts on that. But the last ones did reference this issue of the change to the definition of a fall. And it did also clarify, if somebody falls, there was a part of this that still stands, that if the patient from an intercepted fall standpoint wobbles a bit as part of a therapy balance exercise, that doesn't count. But they did clarify that if this patient starts to wobble with the therapist and hits the floor and hurts themselves unexpectedly, that is a fall. So revisit it, make sure your staff know. The second piece, and almost intentionally, I'm going to drop this with not that much time left because I think you're going to have to sit with it if you're not aware and probably want to go look at it to make sure I am not making this up. When we get new guidance, I tend to immediately go toward, are there new items? Are there changed items? Is the guidance for the item any different? Okay. I see it. Where can we find the new definition for a fall? Go straight to the draft OASIS E2 manual, and it has it clear as day tied to item 1033 and the falls question. Actually, I just go straight to the falls question. It has a nice little table of what that definition is. But we tend to focus on items. There are a lot of overhaul to the rest of the information about OASIS. So they tend to take the new manual, they look back at all the Q&As previously, and then try to get the newest manual as current as possible. So there's a lot of paragraphs about the non-visit discharge. There's paragraphs about who can do the admission and when. And if you look at the language in the draft manual, they put in red stuff that's different. So this is what it was, this is what it is now. So I was perusing that. Okay, clean up some language, clean up some language. And then I hit convention number 9. And convention number 9 reads, and I quote, an agency's software may not, quote, answer, end quote, or, quote, generate, end quote, the OASIS response for the assessing clinician. Let me read it again. An agency's software may not answer or generate the OASIS response for the assessing clinician. And then it moves to convention 10. There's no example. There's no clarification. There is nothing that says if the software generates it and the clinician reviews and blesses it, that's okay. It says no. Now I read this and reread it, hyperventilated a little bit, and I'm like, wait a minute. I don't think anybody's really reading this because I would think that at a minimum, the AI vendors would be saying something about this. That agencies in AI pilots or using generative technology, I mean, this would kill off ambient listening that puts answers in, scrubbing my documentation, putting answers in for me. This says no. So I'm like, why wouldn't there be some sort of discussion about this? This seems like a hammer drop without really informing us about it. So I reached out to regulatory folks at the Alliance who were also not aware of it, who are now investigating it further because there's concern that this may be kind of an end run around true rulemaking process. In other words, this seems to be something that should have been put out with public comment, dialogue ensuing, clarifications asked for, and not just put in as we've updated the OASIS manual. So that is in process as of yesterday. I'm getting some updates about where that discussion may be going. But I think it's important as many agencies are aware of this as possible because this goes live April 1st. And what I have learned from the Alliance is that apparently this exact same sentence was in a Q&A 13 years ago in January. It was not ever put into the manual since. So it was answered over a decade ago, was not put into the guidance manual to anybody can find going forward, and is now dropped verbatim, just that sentence, as convention number 9 for E2. So I was shocked. Maybe I'm the only one kind of freaking out about this, but this seems like it has significant implications given AI's attempt to get into this industry. And I'm going to shave 45 minutes off your visit and I can just listen and put in your OASIS answers. The way this reads right now, no, you can't. So I think there's going to be more coming from it. Keep an eye on our newsletter. If you don't have our newsletter, sign up for our newsletter. We're going to share any and all information we get about this as quickly as we get it. But I'm just shocked, Sherry, there has not been some sort of industry. What the hell? Because, oh my gosh, that's blunt. And that doesn't give anybody wiggle room. Because the ones I participated in, the demos, all say, but the clinician has the final say, the clinician has the final say. This doesn't allow for that. Not as written.
Not as written. And sometimes these shocking things can occur and then they back out 100%. So don't be surprised if you get something saying, oh, I know this was mentioned, but this is how we clarified it in the very near future, because I can imagine how this is going to be reviewed by folks when they hear this. And somebody asked, would this apply to the software adding the BIM score? Potentially, right? It's from Marianne.
Well,
thank you for that question.
I think if you're talking about adding it in terms of scoring it, no, because that's just an automated feature. I have selected the individual responses to the BIMS item and it generated a total score. Same thing would be with respect to the PHQ 2 to 9. I have chosen the answers as the assessing clinician and it does my math. That's not generating the answer. It's part of a tool within the OASIS. I'm still answering the questions. It's just doing math.
Right.
I don't think
having it listen and then pick its own score on the BIMS is not going to be acceptable.
Right. But that's a valid question, Sherry, because as written, there's no leeway. So someone could say, you can't do that math. The clinician has to do it and put that answer in. So again, I was just shocked that it's dropped in this one sentence, that there's no discussion. And it just, for me, conspiracy person that I might be, the timing of this with, we're not going to put the January Q&As out because, we answered stuff, but you didn't need to see it, is kind of like, wait a minute, what's going on? Are you trying to slip this in and bypass rulemaking? And then what do you mean? How do you know that questions you answered for one person in the last 3 months aren't questions that 10 other agencies had but didn't ask? And now they don't know what your answer was because you're not going to post it.
Yep.
So maybe I'm just, a little paranoid at the moment, but it just hit me wrong. And that's why I asked Sherry, I said, we need to put this at least on the radar, starting with today's Q&A and in our newsletter and going forward, because some conversation needs to be had about what they mean by this before it's basically gone from draft to final April 1.
Exactly. And so everyone that's on this call, you probably found out about this through our email or through a colleague. Please share this information. I know a lot of people have a thought in their head that if something is free, there's got to be a catch. The catch is that you have to listen to Cindy and I. That's the catch. And that's pleasant, I hope. And we ask and we request, please send us some feedback on what you think about our Q&A so that we can improve them and have a broader reach. But thank you so much. Cindy, did you have any final questions or final thoughts?
No, now I need to go get something for the headache I gave myself.
You will be getting a notification with a registration link and the recording, and we house these on our YouTube channel. So if you have not subscribed to our YouTube channel, please do, because that's an easy place for those recordings to live so that you can access them whenever you need them. Thank you for joining us today. And please be safe out there providing this great benefit of home health.